This is LiveWell Talk on shoulder replacement surgery. I'm Dr. Dustin Arnold, Chief Medical Officer at Unity Point Health, St. Luke's Hospital. Joining me today is Dr. Blake Eyberg, orthopedic surgeon with Physicians Clinic of Iowa, to discuss shoulder replacement surgery, types of shoulder injuries, recovery process, and more. Dr. Eyberg, welcome.
Thank you for having me, Dr. Arnold.
So you're an orthopedic surgeon.
I am.
Why?
You know, when I was in med school, I actually thought I wanted to be an ear, nose, and throat surgeon. And after my ear, nose, and throat clerkship, I decided that probably wasn't me. And I did it. The University of Iowa requires you to do an orthopedic clerkship. And I saw the first thing I saw was a knee replacement. And there was just something about helping people's quality of life and just having that finite change in a status, going from unable to walk or unable to move your arm, and then all of a sudden you could do those things. And that was really satisfying to me, to change someone's function and their quality of life after they'd been painful for so long.
And how did you, was it serendipity, or how did you gravitate towards shoulders?
So I
know you do more than that. I'm just saying your specialty is that.
So in residency, I just had some great mentors that were shoulder surgeons, and that was really just who I was surrounded by, people who focused on shoulder and who were kind of, if you call them specialists in the shoulder world, and that I wanted to go to I call it a reputable shoulder fellowship program, and then these were people who were able to mentor me toward that end. And then I ended up going to Florida Orthopedic Institute in Tampa, which was an awesome experience. Probably the pinnacle of my orthopedic training was in Tampa.
A little bit better weather than here too.
A little bit.
So let's just start off with what do you see as shoulder injuries?
Mm-hmm. So I would say they kind of come in two categories. I split things in the shoulder, and this is very simplified. It's obviously more complex than this, but you kind of have folks your older patients who are more of the arthritic patient. And then you have, some of your older patients are also, but more younger patients that are, I would say, rotator cuff injuries and things like that. You get even into the younger patients, and you start having more sports-related injuries like shoulder instability. But I would say, in general, I split shoulder injury into rotator cuff or soft tissue shoulder versus arthritis. And,
okay.
And the reason I split it up that way is because the treatment for those is kind of dichotomous and different. So for arthritis, after they've exhausted their non-operative management, you have a shoulder replacement of some type. Whereas with rotator cuff, depending on the source of the injury, whether it's traumatic or more degenerative, you may have a rotator cuff repair that's done arthroscopically.
It has always impressed me, or maybe it doesn't impress me anymore, how the degenerative rotator cuff injury can just happen over time, and the patient never really remembers this sudden event.
Nope.
It just slowly happens. And sometimes the patient will argue with it. Well, it can't be my rotator cuff because I know so and so, and they felt a pop. And
yep.
I'm like, boy, man, it's really acting like that. And MRI says it comes back. That's always impressed me.
Yeah, and I think what I tell patients when it comes to rotator cuff is that rotator cuff tearing in the older population, outside of injury, is really a part of normal aging. So these are attenuated tendons. There's not a great blood supply to these tendons, and over time it diminishes. And you can imagine, think about the range of motion of your shoulder and how much it sees over a lifetime. And I will tell you, if I get an MRI of 50 people, 100 people over the age of 50, I'm going to find 50 rotator cuff tears. And I will tell you that over 90% of those people who have an MRI confirmed cuff tear will have no symptoms. Okay, so and we can say that for a lot of our advanced imaging is that we can find a lot of things anatomically that may not look normal, but that may be of no clinical consequence to the patient.
Now, you talked about non-surgical interventions initially.
Mm-hmm. Yeah.
And one of those is injections.
Yep.
Tell us a little bit about what is injected. Steroid injections?
Steroid injections. So I would say that the pinnacle of non-operative management really starts with physical therapy.
Okay.
When you start having pain in your shoulder, your body tries to compensate. And so you start using your shoulder in a way that it wasn't meant to be used. You start kind of compensating, you start using your traps and pulling it up. And so people start to complain of neck pain usually, and sort of scapular pain when they have a rotator cuff problem. And so going to physical therapy and retraining those muscles is really the pinnacle of treatment, because most people will find that once they go to therapy for 6 weeks, their pain resolves. Now, cortisone injections are also a part of that. I would say that, a lot of what keeps patients from using their shoulder appropriately is that it hurts. And cortisone is a long-acting anti-inflammatory, and especially for people who have a really inflamed shoulder, cortisone can be an incredibly effective way to just really get their pain down to 1 or 0 so that they can actually perform their physical therapy. I think of cortisone's kind of like inflammation's like a fire, and cortisone's like a fire hose, and you put it all right on the fire and it puts it out. Now, it doesn't work for every pathology equally, I would say, but for most people that have a really inflamed shoulder, it's a great way to get you back to baseline so that you can start working on therapy, because therapy is really the mainstay. And making sure you do your therapy at home after you've been discharged from the therapist is also really important for the long-term health of your shoulder.
Interesting. Is there a limit to the number of times you can inject a steroid before you say we need to move on to?
So the short answer to that is yes, but I will also say that I think there's a nuance to that. So when I'm talking about somebody with a rotator cuff problem, absolutely. So when somebody sees me and they have new onset shoulder pain, and they have normal x-rays that don't show arthritis, I'll generally recommend physical therapy and a cortisone injection. And then I have them come back and see me in 2 months. And if their pain has not resolved, or it's maybe it got better, but then it came back, I will send them for an MRI to look for any rotator cuff tearing or other internal derangement that I could address arthroscopically. We also have a discussion about goals of care at that point too, because if I have a 75-year-old who has some shoulder pain and they got better, but maybe they're not way back to baseline at that 8-week mark, but they're doing okay. We may forego an MRI and just say, hey, why don't we see how it goes? Because everybody's a little bit different. I would say in younger patients, I am very judicious with cortisone injections, because long-term effects of cortisone can be detrimental.
Could accelerate
they can, and they can accelerate degeneration. They can cause problems with cartilage, which is why in young people I generally stay away from them.
Now, let's move on to the surgical intervention and what you do. But I want to start that off by saying, as an internist, I don't think patients appreciate how much they walk with their arms. Mm-hmm. Their arms are
part of balance.
It is, and it's easier to have your leg in a cast than your arm in a sling, I think, for balance-wise.
Yep.
So they're big surgeries, but kind of tell us about what does the surgery all entail?
So I'll focus on, like I said, there's kind of 2 types of surgery. There's arthroscopic, and there's kind of open shoulder replacement, which is what we're talking about today. So I would tell you that for open shoulder replacement, and I want to kind of dispel any myths, because interestingly, our arthroscopic rotator cuff repairs tend to be quite a bit more painful postoperatively than our open shoulder replacements in most cases. Not for everybody, in most cases. And everybody has a friend who had a, quote, shoulder surgery, and folks can be a little bit scared of that. Sometimes they say, man, my friend had a rotator cuff and it really, really hurt after surgery. And, the person presenting to me may be somebody with bad arthritis that needs a shoulder replacement, who lives in, 6, 7 out of 10 pain every day and can't move their arm. And I would tell you that person, even on postoperative day 1 and 2, may feel better than they did before they came in. And so it's really important to distinguish that, rotator cuff and arthroplasty are 2 different things.
Sometimes you see that the little lady with bad osteoarthritis, she's 80, she breaks her hip, and you guys do a partial.
Yeah.
And she's like, this is better than prior to,
what it was before.
Yeah, they're like, I don't need pain medicine at all. This is great.
They feel great.
Yeah.
Arthritis is really debilitating, especially as you look at the hip. When you walk on the hip, it's just that's really hard. I will say one thing that I think keeps folks from seeking help with their shoulders earlier on is that we don't walk on our shoulders. So they're not weight bearing. You can kind of, if they need to keep it still, it's easier for them to do. But interestingly, once people realize, post-operatively how much better they feel, they're like, wow, I was in bad shape.
Yeah. Yeah, because of that slow progressive, they
just get used to it. These are generally, I would say, the older generations are tough people and they just live with it. But they kind of start getting this really stiff shoulder, and they realize that they're not really using it anymore because it just doesn't work the way it used to.
So kind of walk us through the surgery. I know there's this topic of reverse shoulder arthroplasty. And I got to be honest, I don't know what the difference is.
Okay.
Can you tell us?
Sure. So in general, there's 2 types of shoulder replacements. There's something that's called just what we call it an anatomic shoulder replacement. That was the original shoulder replacement that was, implemented, probably 60, 70 years ago. Obviously, our implants have changed, but that was what they did years ago. And over about the last 20 years, we've developed in the United States something called the reverse shoulder replacement. Now, the reverse has been in different forms in Europe since the 70s, so it's not a completely new technology, but it was FDA approved in 2004. And so I'll start with an anatomic, and then we'll get into reverse. So anatomic shoulder replacements are really indicated for people who have what I would call end-stage arthritis, who have an intact rotator cuff. So to have a regular shoulder replacement and anatomic, you need an intact rotator cuff. And the amount of deformity on the socket side of the shoulder needs to be an acceptable amount. So our shoulders, the socket tends to start facing backwards as arthritis progresses in the shoulder. And if the socket faces backwards too much, you can't reliably place the plastic socket that needs to go in there for a shoulder replacement. And that's really one of the newer indications for a reverse shoulder replacement, okay? But for folks they're usually a little bit younger, a little bit more active, who have an intact rotator cuff and less deformity on the socket side, we can do a total shoulder replacement, okay? So the reverse shoulder replacement was originally designed for people who do not have an intact rotator cuff, okay?
Okay.
The job of the rotator cuff is to keep the ball centered in the socket. A lot of people want to think that the job of the rotator cuff is to actually move your arm, and to a certain extent it can be, but really the rotator cuff keeps the ball centered in the socket so that the other 19 muscles around the shoulder can move it in space. Okay, and when you lose your rotator cuff for, like we talked about, just regular aging attenuation, that ball starts to ride up in the socket. And as the ball becomes decentered, your shoulder is sort of subtly destabilized, and all those muscles around your shoulder, they're not working at the same lengths that they used to be. And so you can get something called pseudoparalysis, where people can't raise their arm because the shoulder's not stable anymore. And it's not because they have a nerve injury, it's because the shoulder's not centered, okay? So what a reverse shoulder replacement does is, as you can imagine the name reverse, normally the ball is on the outside and the socket is on the inside. We put a ball on the inside and a socket on the outside. And that ball on the inside creates a stable fulcrum for the socket on the outside to rotate around. Okay?
Huh. I always thought it was like a posterior approach or something.
Yep. So there's a guy in Cincinnati that does posterior approach for every shoulder replacement. He's the only person in the country that does it. It's very interesting.
Wow.
No one else does it, though.
I had a patient one time that I had seen him for something else, but he had the rotator cuff arthropathy, where he just had it just degenerated to the point that it formed like a new joint, and just
absolutely
nothing he could do for it.
Yep, and that's like, I would say that was the initial indication for reverse shoulder replacement, was these folks who had long-standing rotator cuff tears, that their humeral head had risen all the way up, and because of that destabilization, they developed the arthritis, which we call rotator cuff tear arthropathy, which is distinguished in some ways to just regular old arthritis.
Now, every patient, the first question they ask, how long's the recovery? Tell us about the recovery.
So I would tell you, I put the recovery into phases, okay?
Okay.
Most people who are appropriately indicated, meaning they have end-stage arthritis and debilitating pain, their pain is going to be better by 2 weeks. They're going to feel better from a pain standpoint almost, I won't say immediately, but very quickly. All right. The rehabilitation is a little bit slower in terms of getting our function back. So for myself, my rehab is that I start them in physical therapy at 6 weeks. All right. At 6 weeks, they work on range of motion, getting all of their range back with their physical therapist. And then at 3 months, they can start strengthening it, and they have no restrictions at that point. So I would say, like, full, no restrictions, do whatever you want with it, is 3 months.
Okay.
But in terms of just the relief from the pain is nearly immediate.
We've stressed that on previous podcasts about how important that post-operative therapy is when we talk about knee replacement. I'm sure it's the same with shoulder.
It is. It is absolutely critical. We have some folks who are a little more self-directed and can kind of do it on their own. But I would say that particularly with the shoulder, because as you say, you don't have to walk on it. It's very easy to ignore it if you want to keep it in a sling. So it's important to go to your physical therapy visits and make sure you're working on that range of motion, because you can get stiff after these if you don't work hard.
So do patients had shoulder surgery, do they go home or do they stay the night in the hospital?
So my patients generally stay one night in the hospital,
Okay.
but we certainly do have some patients that are going home. The total shoulder is not presently on it's not off the inpatient only list from Medicare, and most of my patients are Medicare. So everything is being done in a hospital versus, say, a ambulatory surgery center at this time. I do think, just like most things, that is where this is going to move, and that I think select patients will be going home the day of surgery, and some people already do.
What's on the horizon for shoulder?
What is on the horizon?
Yeah,
so
what do you
think
see happening?
I think what we're trying to sort of bridge the gap right now between the person that has a rotator cuff that's not repairable, but is presently not ready for a joint replacement. Okay, because as you can imagine, somebody that has a long-standing rotator cuff tear, or maybe they've even had a rotator cuff repair in the past that has failed, those sometimes are not repairable, but they have painful rotator cuff tears. So you can't fix it arthroscopically. So what do we do in between the person who has arthritis or rotator cuff arthropathy and the unrepairable painful rotator cuff repair? And I don't think we know the answer to that. One of the things that is being used right now, even in here in Cedar Rapids, is something called a balloon arthroplasty. I have not performed this procedure myself, but it's kind of all the rage on the circuits, the orthopedic circuits right now. Is arthroscopically they will insert basically an angiocatheter with a balloon in it, and it inflates with saline, and it pushes the humeral head down to stabilize it. And it kind of, I told you that when the rotator cuff tears, it kind of rides up. It just stabilizes it in kind of the way that a reverse does. It's not a permanent operation, but it may provide people some relief. Huh. And I would say that level 1 trials are presently underway for that. We just don't know the answer.
Wow, that's interesting. Oh. I always say I'm not the type of person that would ever be innovative in that. I would never think of doing something kind of out of the box like that.
Yeah.
I always say that if I lived, in the Middle Ages, they told me the earth was flat, I go, all right. Just kind of go about my business. I wouldn't. But Dr. Eyberg, thank you for joining me. I know you're busy and informing our listeners about shoulder replacement surgery. Once again, this was Dr. Blake Eyberg, orthopedic surgeon with Physicians Clinic of Iowa. To learn more, visit unitypoint.org. Thank you for listening to LiveWell Talk On. If you enjoyed this episode, don't forget to subscribe. And if you want to spread the word, please give us a 5-star review and tell your family, friends, neighbors, strangers about our podcast. We're available on Apple Podcasts, Spotify, Pandora, or wherever you get your podcast. Until next time, be well.